Hey guys, can you all hear?
Hello.
Can you all hear me all right?
Yeah.
Okay, perfect. Did everyone have a good time off?
Yeah.
That's good. I know it's hard because we have all this content we're supposed to be doing, even though you guys were off. Kind of messed up the way that's set up.
Yeah. Yeah, definitely.
So
So,
what I'm planning on doing this morning, I want to go ahead and do a little bit of review for this first part of class, and then for the second part of class, I'll go over some new content with the cardiac stuff. And then when we do lab today, if there's anything I didn't finish with the cardiac stuff, I'll kind of finish it there. Um, and then in lab, we have a few things that we need to talk about as far as skills that I want to make sure you guys feel okay with. So we'll do that as well. Okay.
Okay.
All right. It looks like it's 9 o'clock, so I'm just going to go ahead and get started. So I sent you guys that things to know. Did everyone get that okay?
Yeah, I got it.
Okay, perfect. All right. So on this test, there are probably like 13 or 14 questions on diabetes. So that's like the first portion of the test. So if I asked you guys to tell me signs and symptoms of hypoglycemia, what would you say?
Dizziness?
Dizziness, okay. What else?
It would be like shakiness and anxiety.
Okay, that's part of it.
Would
Probably,
you maybe see confusion?
yeah.
Yeah, I was gonna
So, especially like if they get down really low, they can be confused for sure. And like probably the number one thing that you would see when someone has a low blood sugar episode is probably going to be sweating or diaphoresis. So keep that in mind as well. So, what are you supposed to do when someone has a low blood sugar? How do you decide how to proceed?
if the patient is still awake, I guess you give them like, I think you mentioned it last time, so you give them like orange juice or something, like, through the mouth. But if they're not awake, you don't give them anything in their mouth. So you give them, I think, through IV, something like
Yeah.
that.
Yeah. So this is really important to know for this test, you guys. So when someone has a hypoglycemic episode, one of the first things you do is you assess how with it they are with you. So if they can talk to you and they're able to follow commands, then you're going to give them something oral, right? Because oral replacement for their blood sugar is going to be better for them, because remember, we don't like those big shoot ups of their blood sugar. We want everything to kind of stay even keel. And so if we just give them something oral, it'll help bring them up slowly and like kind of keep them up there for a while. So things that we would do would be, yes, you could give some orange juice, like you said, Stella. But you could also do some other things, So if you didn't have orange juice, you could give apple juice if you had apple juice. If you had something like a glucose tablet, or even if you had pop, like soda pop or something,
Yeah.
you don't want to give like a huge amount of that. You just want to give a little bit of it to help bring their sugar up.
And we also do have the oral glucagon, right?
Yes, yes. So any of those things would be fine to give them to bring their sugar up. But then after you give that, just remember, you're checking their blood sugars every 15 minutes during this low blood sugar episode. So you want to make sure that even after they come up, you still need to give them a snack to eat afterwards as well. So like, maybe a cheese sandwich or graham crackers and peanut butter and some milk or something like that. Because even though you got them to come up, you're worried that they're going to go back down. So if you give them that other snack, it'll kind of help keep them even keel. Okay? So that's really important. If this person is not with you enough to cooperate and they're just kind of out of it, you are going to go ahead and give them IVD50, or you can give them glucagon. And remember, glucagon you can give in multiple different ways. So you could give that IV, you could give it IM, and like she said, there's an oral version of it as well. So there's a bunch of different ways you can give it. But obviously, if they're not with you enough, you don't want to give anything oral because you're going to make them aspirate. So anything you would do, you want it to work quickly. If we give something IV, that's going to be the quickest way, right? But the problem with IV is it makes your blood sugar shoot up a lot. And so, yeah, we get them to come up, but we don't want to have those big spikes because it causes like that yo-yo effect with your blood sugar. So after we get them to come up, again, we're going to give them something oral because at that point, they're going to be with you enough to be able to talk and cooperate. So that's kind of how you have to think about with the low blood sugar stuff. Make sense?
Yeah.
Okay. All right, a couple other things that they hit on here. I want to talk about something specific that they have on this test because I don't know that. I just think it's kind of a crappy question, honestly. So do you remember when I mentioned something about the Somogyi effect and the dawn phenomenon? Do you remember that? It's okay. If you don't, you don't, but no? So both of those two things, what happens is you have this process that happens when you sleep, and you have these hormones that get released as you sleep. And so like around 2 in the morning is when you start having these crazy things happen with your blood sugar. So there's a specific question in here where they talk about this person is type 1 diabetic and they get insulin. So they get NPH insulin in the morning and the evening. And they also get Lispro, which is that like equivalent to Novolog or Humalog. And they get that like as a sliding scale with their meals. So it says the nurse notes that the client experiences hyperglycemia, so a high blood sugar, around 6 a.m. So which of the following would be the best actions by the nurse? So the whole rationale for this question is saying, oh, they think that maybe they're having one of those things, the dawn phenomenon or Somogyi effect. Because when you have that, it causes hyperglycemia because you have like, this episode around 2 a.m. where you have like a really low sugar and then it goes back up really high. So the whole thing with this is they're saying if you check their sugars at 2 a.m. for like a week, you can tell if it's from that, and then you would decide what to do from there. So like the other things that they have as options on here, they said obtain a prescription to increase the evening mealtime dose of NPH. Well, that's probably what you would do if they have one of these things wrong, but you have to confirm that that's what's wrong first. Then it says encourage the client to eat a carbohydrate snack before bed. I mean, sure, maybe, but you don't know what exactly is going on here. So the whole point is if you make a point of checking their blood sugar around 2 every evening for like a week, you would know for sure if that's what was going on. The other thing is advise the client to check blood glucose levels 2 hours after waking up. That one doesn't make sense because, I mean, you know, the whole problem is that you're waking up with a really high blood sugar. So something's going on during the night that is causing this to happen. Do you guys, are you following me with this?
So it's just like kind of like your blood sugar gets high like between 2 to 6 a.m. kind of thing.
Yeah. So like you get these hormones that automatically release during nighttime when you sleep.
Right.
And so this automatically happens regardless with everyone. But with a diabetic, someone who really already has issues, it makes it even worse.
Okay. Got it.
But for that question, it's only one answer, which we already know.
Yes,
Okay.
it's only
good.
one answer. So I just didn't, I mean, to me, if I was reading that, I would not have got what they said was the correct answer. I'm like, you know, I just think they could have found a better question about Samoji effect or dawn phenomenon. That just is crazy. Okay, let me keep going here. All right, so do you guys remember when we talked about diabetic ketoacidosis? So remember we said that when someone has that, typically they're going to be a type 1 diabetic, more so than type 2, right? So you typically that's who's going to have this. We said there's 3 causes for it. So either, you know, they just didn't take their insulin for one reason or another, or maybe they didn't know they were diabetic and this is their first time figuring that out because they went into DKA, or maybe they had a sickness or an illness that kind of set them off into this, right? So those are the 3 causes. When you have this, you have high blood sugar, right? So it's like higher than normal. And then what else do you have that would be like signs and symptoms associated with DKA?
Ketones in urine.
Say that again?
Is it? I don't know if I'm saying it right, but like when you have like ketones in urine or whatever.
Okay, yeah, ketones in your urine.
Yeah, ketones in urine. There you go.
Okay,
Wouldn't you have the fruity smelling breath?
yes, definitely. What else?
Frequent thirst.
Okay. What else is like really specific to DKA? What's your respirations like?
Isn't it like rapid breathing or like shortness of breath?
Kind of, but there's a specific word for that.
Tachycardia.
It's Kussmaul breathing. So remember, so Kussmaul breathing is where when you have DKA, it's really specific. When you watch someone that does this, it seems like they're really having a hard time, that they're really short of breath and whatever, but that's not really what the issue is. They're doing that because their blood sugar is so high. So I can't remember. Did I send you guys that video to show you that before? Do you remember watching a video about that or no?
No.
Okay, I'll send that to you guys. That when we have a break here, I'll see if I can send it to you in an email or something so you can watch it. It's really significant. In this video that I'm talking about, there's this little boy who's probably like, I forget, 3 or 4, so I don't know, he's not really that old. And in the video, this doctor is talking and he's talking about Kussmaul breathing and what it is, and he like videotapes this kid doing it. But then he talks about this kid and what kind of what happened with him. So this kid was fine the night before. His mom put him to bed. She took his blood sugar before bed. It was 99, so perfect, no problem. But then when she went to wake him up in the morning, she had a hard time arousing him, and he was breathing like this. Okay, so she's like, wow, something's wrong. And then she took him to the hospital. Well, here, this kid had a tooth abscess, and that's what set him off into this DKA episode. And they actually like list all of his labs that go along with this, and they're crazy off. Like, you should see how bad his pH is and all this stuff. It's just like way off. So it's kind of interesting. It's nice to be able to see what it looks like and like put all the pieces together. So I'll send you guys that. But anyway, there's a question here about DKA, and it talks about some of these signs and symptoms that you see with it. So it says, you know, you're caring for this person, they're having nausea, vomiting, abdominal pain, Kussmaul respirations, fruity scented breath, and it says, what should you do for this person? What would be like a important intervention to do for this person? So let's think for just a second, what's going on with DKA? So remember, we have this osmotic diuresis that's happening. So we are putting out a ton of urine right now as a result of this episode, right? So we're putting out all of this urine, we're getting super dehydrated. And then we are like our electrolytes are getting all messed up as a result of this too. So our electrolytes are all out of whack. Obviously, you know, your blood sugar is up really high, so that would be a concern as well. And then like you go into metabolic acidosis. So you have a ton of different things happening. So the whole point in this question is, like the options are, hey, would you apply oxygen via a face mask? Would you implement seizure precautions? Would you obtain a blood specimen to evaluate potassium? Would you rapidly administer normal saline IV? What would you choose there?
Saline IV.
Yes. So yeah, like the one option about the potassium, sure, that's kind of important. You probably would do that, but it's not something you would do right off the bat. Okay, so this whole thing with them being really dehydrated and stuff, that's a big deal. And so you actually do, you know, take care of that as one of the first things that you do. Okay. When we talked about DKA, we also mentioned something called HHNS. So HHNS is very similar, right? We said someone who had that would be someone who is a type 2 diabetic. They usually, you know, present the same way, so they look pretty similar. The only things that are different would be they don't have ketones in their urine because they're not a type 1 diabetic. And this whole process doesn't go that far to where you do have to like metabolize your fats. You know, it like stops at a certain point. So you still have all of that dehydration going on. You still have a high blood sugar and all that kind of stuff. You still, you know, may be having your pH all out of whack, but like the rest of it doesn't happen like it does with DKA. So for this person, it's usually going to be an older adult. So you always look at the age, you know, so it's not going to be someone who's super young. And then usually it's going to be some kind of sickness that set them off. So a lot of times people don't come in right away for this because they think it's something else, you know. And so the thing that usually makes them come in is when they start presenting with confusion. They start getting like some neuro symptoms. So then they're like, oh, something's wrong. And then they come in and get looked at. So with this, your blood sugar is always going to be really high, like higher than DKA even. And again, you're going to treat them kind of the same way as you would the DKA person. Do you guys remember talking about that? No one's talking. Do you hear me?
Yes, we do.
Okay. Do you guys remember talking about that though? Do you remember that? Because you have a question about that on here. Okay, so a couple other things that they hit on here. Um, so I think when we talked about this, I can't remember how I presented this to you guys, but we talked a little bit about oral diabetic meds. And so what do you guys know about glipizide?
Doesn't it have like, I don't know if I'm thinking of the same medication, but the medication I'm thinking of, doesn't it help your body? Is it produce insulin or something like that? I don't know.
Yeah, kind of. I mean, you pretty much said it, but so for this question, they're asking you about what the mechanism of action of glipizide is. So how does it work? So when someone takes this, it helps stimulate your pancreas so that it makes insulin. That's a simple way of saying it.
All right.
All right, I don't know if I talked to you guys about this or not, and hopefully you had it somewhere in your reading, but there's a question about an insulin pump. So when someone has an insulin pump, typically it's going to be a type 1 diabetic that has it. You never really see a type 2 diabetic with one. And remember, an insulin pump is really tiny. It's going to be almost like the size of a pager, if you've ever seen what a pager used to look like, which I don't think anyone even carries a pager anymore, but they're really small, you know? And so this insulin pump, it's going to have a really tiny little syringe inside of it that's filled with insulin. And usually, you know, it's going to be like regular insulin because that's the fast acting insulin, right? So it's real tiny and it has like a little bit of tubing to it. And then it attaches to like some type of needle. And the needle would go into your abdomen somewhere. And then you would just like put some type of dressing over it to keep it there. So it's not like it's sutured in or anything crazy like that. So with an insulin pump, when someone has this, they get a little bit of insulin throughout the day. So like it's a real tiny little amount because it only carries a little bit. So they call this a basal rate. So they constantly get this little bit of insulin infused into their body throughout the day. But then when they eat, they have to dial in a little bit more insulin every time they eat for this pump to give them more. So that's where like counting carbs kind of comes into play. Like this person would have to know how to count their carbs. And then like their physician would have specific instructions for them and say, okay, if you had this much carbohydrates when you ate, then you're going to give yourself this much insulin. And so they would know how much to dial into their insulin pump. So with these pumps, you can like take them on and off really easily. So like I used to know a girl that my daughter goes to school with who is diabetic. She's a type 1 and she has an insulin pump. So whenever she plays sports, she actually takes it off for a little bit while she's in a game and then she'll put it back on. But like you can take them on and off like when you go to shower and you know whatever, that kind of thing. But for these, you don't want to leave that same needle in the same spot forever, right? So you're going to get infected if you do that. So you're supposed to change that needle and that site every 3 days.
So you don't have to change like the actual pump, just the needle in the pump?
Yeah, so the needle part is what you need to be changing every 3 days. Now, obviously, the syringe inside the pump that's filled with insulin, you're going to have to change every so often as well because it only has so much in it, you know? So you have to put a new syringe in occasionally, but yeah. So just when you know how sometimes when you're on these tests and you look at how something is worded and you're like, what the heck does that mean? I just want you to understand what basal rate means. Basal rate means that you're getting a little bit of insulin throughout the day. It's continually infusing.
Okay. So the question pertaining to this insulin pump is the basal rate and not how many days it's been changed. Is it a multiple question or just?
No, I'm trying to make you understand the question more by explaining this right now. So
Okay.
the question itself is about, it says the nurse is evaluating teaching with a client who's receiving continuous subcutaneous insulin via an insulin pump. So which of the following statements by the client indicates that teaching was effective?
Okay, then the basal rate understanding.
So when you read your options, then hopefully you'll understand a little bit better on how to choose the right answer, is what I'm telling you. Because one of the options says something about a basal rate, and I just want to make sure you understand what that means. Doesn't mean that that's the correct answer, but I'm just telling you what it means so you understand. Okay, when we have someone with DKA, we have to give them IV insulin, correct? So what kind of insulin do we use for that? There's only one kind of insulin that you can give IV. What is it?
Isn't it the Lispro?
No. It's regular insulin. It's always going to just be regular insulin. So when you give this to someone, you get it from pharmacy and it comes in this little tiny bag and it constantly infuses. You know, it's like a, not really an IV piggyback, but it kind of looks like one because it's small. But yeah, so this person would be hooked up to this in the IV and it would constantly be dripping and you'd be checking their blood sugars all the time, you know. And then once their blood sugar gets to a certain point, then you're going to be like, okay, I think they're down enough. Now I can switch them to, you know, regular subcutaneous insulin again. Okay. I think that's pretty good for the diabetes stuff. There's probably a couple more that maybe I didn't say, but that for the most part, that's a lot of what was on there. All right, so that's the first portion of the test. So that's like probably 13, 14 questions of that stuff. And then it gets into like the pulmonary stuff, okay? So I don't know how many of you guys listened to anything that I put on Canvas, but I put stuff on there over break on purpose, so hopefully you guys would, you know, keep up with this, all of this. There are a few things that talk about like upper respiratory things, like, you know, like the flu. There's some stuff about the flu on here. There's stuff about like someone who's hypoxic. If I asked you, when someone has hypoxia, so all hypoxia means is you're not getting enough oxygen in your bloodstream, right? So you don't have enough oxygen there, so you're not taking enough oxygen to all the tissues in your body, so it's a big deal. So when you start getting hypoxic, what would you look like? What would be some of your signs and symptoms? Like
Cyanosis. I can't believe.
Think early signs, because you wouldn't be blue right away.
Yeah.
That would be a later sign.
Tiredness.
Okay. What else?
Fast heart rate.
Heart rate. Okay.
Would sweating be like a late or early sign?
I would think that might be a later sign.
Okay.
So when you're thinking early signs, you're going to think,
Confusion.
maybe not right away. That would be more of
Okay.
a later sign.
How about slow heart rate,
Well, here I'm
coughing?
gonna read off some. Okay.
Okay.
So restlessness, that would be a big one. That would be early. Tachycardia, so you're actually going to have a higher heart rate because you're having a hard time breathing, so your heart rate's going to be working, right? You are going to have dyspnea, obvious, right? Shortness of breath. And then hypertension. Those would be early signs. When we're talking late signs, we're talking things like hypotension, cyanosis, use of accessory muscles, any of those types of things. So like the sweating and stuff probably would come in there because you're working so hard that you're making yourself sweat and everything. Okay, there are a couple of like assessment type questions that they have on here that have to do with like one of them's stupid. So this one has to do with when you're assessing someone that has pneumonia and you're doing percussion, because how often do we all do percussion, right? So usually it's a nurse practitioner or someone like that who does percussion. We don't generally do that. But if you were assessing someone with percussion, meaning that you're like tapping on them to try and see the sound that you get. So if someone has pneumonia, they have like fluid collected in their lungs, right? So what do you think that sound would be like? Would it be resonant, timpani, flat, or dull?
Dull.
Dull. Mm-hmm. So because you have fluid in that area, you're going to hear a dull sound because that kind of, dulls the sound that you're making, all that fluid. All right, what do you guys know about a friction rub? You know how when we talk about how things sound, like crackles and ronchi and all that, we know what all that sounds like. But do you know what a friction rub sounds like?
Isn't it like a short sounding sound, like like a short, almost like explosive kind of sound?
Not really. It's more like a grating sound, like something's rubbing up against something else. So usually you're going to hear it on inspiration. So if someone has a friction rub and you're listening to their lungs, you hear it on inspiration. And usually it's because, here, let me see if I can draw this for a second. Let me get on the whiteboard for a minute here. Okay, so like if this was someone's lungs here, I'm just going to draw one lung. You have this little space that you have between your lung and the outer portion of the part that kind of like encases your lungs. There's this little space right here. It goes all the way around. So inside this space, this is called the pleural space, you have a little bit of fluid in there normally, all the time. Because as your lungs expand and contract, it just helps that whole action. So it's not like rubbing on anything and like I don't know how to explain that right. So it's not like you need that fluid to make that action a little bit better, more efficient, I guess you could say. So when someone has pleurisy, pleurisy means that you have an inflammation of this pleural lining. Okay, so this lining here would be inflamed. So maybe, you know, you would have, I'm not drawing this very well, but like you have a little bit of swelling going on in there. So that space is a lot smaller now. And so it might be so swelled up that your lung actually rubs against that pleural lining. And that's what's causing that friction rub. Do you see what I'm saying?
Yeah.
Yeah.
So it's just that action of rubbing. And it sounds like something's grating against each other. It just totally sounds like rubbing when you listen to it. So that's what that's about. There also is a question that talks about, let's see if I can find it. Talks about a pneumothorax. Oh, here we go. Okay, so when someone has a pneumothorax, again, let me see if I can draw this here. There's my lung. Here's my pleural space. So if I have a pneumothorax, it means that, again, this pleural space, there's a problem here. So like I have a collection of air or fluid that gets in here, even more so than the fluid that's already in there. And so if stuff accumulates, then you're going to have like an area like this, where all of this would be filled with air or fluid or blood. And so now you have a smaller space here for your lung to expand and contract. So you're going to have shortness of breath and things like that because of all of this stuff that's accumulated here. So when someone has a pneumothorax, they're typically going to put in a chest tube. And a chest tube is going to go in that pleural space. So it's not in the lung, it's in that space between. And that the whole purpose of the chest tube is it's going to drain that extra fluid out of there, or if it's air, you know, you drain the air out of there so that this space gets smaller. And so it's not going to be an issue anymore. So when someone goes for a procedure, like say they have a pleural effusion. So a pleural effusion means that they have a collection of fluid inside that space, and it might be like, it could be infected fluid, or it could be like cancerous cells or whatever that caused this to happen, this pleural effusion. There's a bunch of reasons for why you can get one. But when they have this, it affects their breathing. So typically a physician will send someone for a thoracentesis. A thoracentesis is a procedure where they would go in and they would drain that fluid. They do this under fluoroscopy. So they have this big needle that they stick in. They stick it in their back and they draw out all of this fluid. So you could tell, you know, anytime you do any type of procedure like that, you know, anytime you're anywhere near the lung, and this, if you ever see one of these needles, they're like humongous. So you could tell you're really close to all of that. So you could easily like nick the lung or something. And then if you nick the lung, then you're going to have all this extra air in this space and you'll have a pneumothorax, right? So that's kind of what this question is about. So this person goes for this procedure, and it says, which of the following assessment findings requires immediate attention by the nurse? And so what do you think you would find if someone had a pneumothorax, like assessment-wise?
Crackles.
Not crackles. You're going to have diminished breath sounds. So if you were listening to them, you're not going to hear a good air exchange there. because they don't have that area to like expand and contract like they would. So you're not going to hear a real good air exchange. So that's one thing that you would see. What are some other things you would see? Think about what we were just talking about with hypoxia. You'd probably see some of those same things. So because they don't have that good area to expand and contract, they're going to get hypoxic. So you're going to see a low pulse ox. They're going to seem short of breath. They're probably going to have a high heart rate and maybe a high blood pressure at first when this happens. So you're going to be watching for some of those things. Make sense?
Yes.
You guys, do you know what pertussis is? Have you heard of that?
Pre what?
Pertussis.
Pertussis. Mm-mm.
I feel like I've heard it when I feel like it's on TV when they talk about like, isn't it a whooping cough or something?
Yeah, exactly. That's exactly what it is. So you do have a question about that. So it says, when you're assessing someone with pertussis, which of the following findings would you expect to observe? So what does someone with pertussis sound like when they cough? They have such a horrible cough, like it's really strong, and they cough so much it's almost like they can't catch their breath. So when they do like try to take a breath, you hear like this in between everything. So it's really significant. You'll never forget it if you ever hear that. There is also a question about someone with a tracheostomy. They talk about like suctioning someone that has a trach, and so you would need to know like the steps. So this question specifically is going to list a bunch of things, and you have to put it in the right order on what step you do when.
Did you say with a suctioning or tracheostomy care?
Trach suctioning.
Trach suction.
All right. Do you guys remember much about ABGs, like how to read one?
Yes, I think so.
Okay, the one question on here, it's just one question, but it has ABGs on it in the options. So like the question is about someone with COPD. They're in for a COPD exacerbation. And it says, which of the following results would indicate to the nurse that the client's condition is getting worse? So if you were looking at ABG results where it just has a pH, a CO2, an HCO3, and a PaO2, how would you know they were getting worse? And honestly, think back to when we talked about like respiratory acidosis, alkalosis, metabolic acidosis, metabolic alkalosis. So where would someone with COPD fall in there? Would they be respiratory acidosis, alkalosis, or would they be metabolic acidosis or alkalosis?
Would they be on respiratory acidosis?
Yes, so they would be under respiratory acidosis because remember back when we talked about that, we said someone with acidosis, respiratory wise, would be someone who is having a hard time ventilating, right? They're hypoventilating, they're not getting enough air. And so all of the things that we listed that were possible causes were all like respiratory type things, right? So that's where this person would fall. So when you're looking at those, then you're looking for something that's respiratory acidosis. But then the other thing that you need to look at is the PaO2. So if your PaO2 is low, then that's showing you they're having an issue, right? Because that oxygen level is just not good. I was going to write some on here, but I guess I don't think we need to. All right, there are a few questions that have to do with, like there's a couple about TB, a couple about asthma, but the hypertension questions. So these, a few of these have to specifically do with medications. So like there's one about lisinopril, there's one about diltiazem. So make sure you're really looking at those closely. There's another one about hydrochlorothiazide. So if I asked you guys, what's something that you need to be remembering specifically about lisinopril, what would you say? First of all, what category is lisinopril in?
An ACE inhibitor.
Yes, it's an ACE inhibitor. So knowing that, think about ACE inhibitors now, and what are some important things to remember about ACE inhibitors?
What's your question? What we have when with ACE inhibitors? Was that a question?
What are some important things to remember about ACE inhibitors?
Angioedema, coughing,
Okay.
elevated potassiums,
Okay.
low heart rate. Potassium retention, all those stuff.
Yeah. That's how you need to be thinking when you're looking at these questions. So you say, okay, what category is this in? And what are some important things to remember about this particular med? And so all those things Gloria just said, yes, that's what you need to be thinking about.
But then the question, will it be asking specifically on each of the medication, or they'll come with, with these set of medications?
It's specifically about the medication.
Okay.
So there are, I think, 2 questions on here that have to do with delegation. Do you guys feel comfortable with delegation questions? Do you understand how to figure out what you would choose?
We can go over it. It's just that sometimes there are some tasks that we think can be delegated. I think I can delegate, but it's really not.
So if you were delegating something to an LPN, and this is all in that hypertension question stuff. So you're working with an LPN and you have someone who has hypertension. What things would be appropriate for you to delegate to this person? So would you be able to delegate for this person to do a referral to a dietitian?
No.
Would you be able to tell them to educate the patient about disease management?
No.
Would you be able to have them administer their blood pressure medications?
No.
It's,
Yes.
Would they? Oh, yeah, okay.
And then would you be able to tell them to evaluate the trend in their blood pressure measurements?
No, they can't evaluate.
They
They
can't
can
do
only
evaluation.
the
Correct.
vitals.
So that's how these delegation questions are. So yeah, so an LPN can give the blood pressure medicines, but for those other things, no, that's not in their scope of practice.
So these they are delegating to an LPN, not a NAP.
This is to an LPN.
Okay.
There's one other question that's a delegation question, and this would be to an unlicensed assistive personnel. So that would be more like a nursing assistant.
Mm-hmm.
So I think you'll be able to get that one. That doesn't seem that bad. Do you guys know anything about the DASH diet? DASH DASH diet?
isn't like, don't they do the DASH diet because they don't want them to have like a huge amount of sodium? They want them to use like sodium substitutes.
Yeah.
So like literally like, because they have this like seasoning called DASH.
Yeah. So when you're on the DASH diet, this is specifically for people who have high blood pressure, and the things that are emphasized in the DASH diet would be to have more fruits and vegetables than anything, right? So you have a big amount of those, and you eat low fat things, whole grains, fish, beans, those types of things.
Yeah, because we have a gentleman on my unit that is on the DASH diet right now, and every time I come in there to do his vitals every like 4 hours, he's always like, I can never have salt. And he goes, all I want to do is just shake some salt into my mouth.
Poor thing. That's funny. Yeah, anytime you're restricted from something, you just want it even more, you know?
Yeah.
So I feel for him. That's horrible. All right. There are a couple of questions about cystic fibrosis too. So I believe that's one of the things that I recorded for you guys. So cystic fibrosis, remember when you have this, it can affect a couple of things in your body. It's not just your lungs. So usually they get this, it's passed down from their parents, and usually both of them have to have like the gene to give it to their kid. And when they have this, you can have lung issues or you can have GI issues, or sometimes both, you know. So I know twins who have cystic fibrosis. They're the same age as my boys, so they're about 14. And both of them have a different type of this. So the boy has the lung portion of this, and the girl has the GI portion. So the boy, he constantly has all of those thick secretions, right? So every day, they're religious about this. Every day at home, you know, he takes like 3 million different medications, right, to help him stay healthy. And he's more at risk because he has cystic fibrosis for picking up different bugs and things and getting really sick from that. So they try their best to keep them as healthy as possible. But anyway, every day when he gets up in the morning, he does all that chest physiotherapy stuff. So they have their own, like, I'm sure he has like nebulizer treatments that he does. And then they have like their own vest thing that shakes him to get some of that stuff loose. And then they smack him on the back to get some of that stuff out. And like every day they do this, like multiple times a day. The other thing with him is they make sure that he's very active. So he's in every sport under the sun so that he can like keep his lungs working well, you know? So he's, you know, he does everything. So football, wrestling, you name it. So that's the boy. The girl, she has the GI portion of this. So your pancreas like helps you make these enzymes to digest your foods right. And so because she has this problem, she can't digest foods the right way. So she always feels like sick to her stomach. She is she has problems with her weight, like her weight's always really low. She's underweight. Like there's times where she can't eat anything. It's just really bad. So there have been times where she's had to get a feeding tube and get, nutrition that way. She has to take pancreatic enzymes. So pancreatic enzymes are pills that you have to take every time you eat to help you be able to digest these things. So the way that you know those work right is by looking at this person's stool. So the stool is going to look more normal when you're on pancreatic enzymes. When you don't take those, your stool's going to look real fatty and like greasy and fatty. I don't know how to explain it. It's just different. Like you're not digesting things the right way. So I don't know, when you read about cystic fibrosis, they talk about like, the way that they figure out that someone has this is they do something called a sweat test, and they test that, and that's how they figure out they have the cystic fibrosis. But in the one question that we have, it talks about someone has cystic fibrosis and it's summertime and they're outside and they have increased sweating and weakness as a result. So which action by the nurse would be most appropriate? So what would you tell them to do?
Can you repeat that question again? I'm sorry.
So they have increased sweating and weakness during the summer months. So they have cystic fibrosis, and so what would you tell them to do for this? They say you should increase your dietary salt intake to your meals is what you should do. And then when I'm reading the rationale, it just says added dietary salt is indicated whenever sweating is excessive, such as during hot weather, when fever is present, or from intense physical activity. All right, one more thing before I'm just going to stop at 10 here with this stuff and we'll go on with our other stuff. So there's a couple things about pursed lip breathing on here. What is pursed lip breathing and why does it help someone who has COPD?
Doesn't it help because you're able to get like it like slows down like the person's breathing, so you're able to get like more into the lungs, right?
Kind of, yeah. So with COPD, you can get air in, but it's trapped in there and you can't get it all out. So with pursed lip breathing, it's like you're almost like you're blowing out a candle. You're going like, so it's like, yeah, it helps you slow down your breathing and it helps you be able to get some of that trapped air out by doing that.
Okay. So what would you just like breathe in through your nose and then try to breathe out through your mouth kind of thing?
Oh, here, this says pursed lip breathing techniques assist in prolonging the expiratory phase of respiration and decrease air trapping. I'm sorry, what was your question?
So would you just like kind of like breathe through your nose and then try to like breathe in through your nose and then exhale through your mouth kind of thing, or it doesn't?
Yeah.
Okay.
All right, so we'll stop there for that stuff. I just wanted to get through some of that with you guys to make sure you felt better about some of those topics. Did that help a little bit?
Yeah.
All right, so today we're supposed to get into some of the cardiac stuff. So I'm going to pull up one of the PowerPoints that I put on Canvas. Let's see if I can find it here. There we go. Oh, darn it. Hold on. There we go. Okay, so we're talking about coronary artery disease and acute coronary syndrome. So remember, you guys do have that Med-Surg ATI book that you can look in for some of the stuff, and it is very helpful. So I would encourage you to look in that at some of these topics because it'll make more sense for you. So when we talk about coronary artery disease, we're talking about people that have atherosclerosis. So what atherosclerosis is it's like fat deposits that get inside your vessels, and it doesn't happen like overnight. You know, it happens over a long period of time. A lot of times they refer to this as hardening of the arteries. And over time, if you can just imagine inside your vessel, as more and more plaque gets in there, you can't get blood flow through there, so you're going to have more issues over time. This is atherosclerosis is a major cause of CAD. Usually if people have problems with their cholesterol level, they're probably going to have an issue with this. So you always want to watch people's cholesterol. This kind of shows a little bit about the stages here. So like here in B, you have a little bit of fat in there, but not a ton. And then look at C, you've got more. And then D, you've got even more. So it can cause lots of problems over time. So down here at the bottom, it says this is a progressive disease that develops over many years. When it becomes symptomatic, the disease process is usually well advanced by that point. So typically, like maybe right now, we all have some of this and we don't even realize, but then later on in our years, we'll figure it out because we'll start to get symptoms. So with these different stages, it starts with like these fatty streaks inside your vessels. They develop within the smooth muscle cells, and then you start to get these fibrous plaques. So you actually get changes within the walls of your arteries, you know, from this. These changes can appear in the coronary arteries by age 30, so that's pretty early. And it can increase with age. So once you have this injury, then you know it's a big problem. So you have to really watch your cholesterol and things. And then when you get to this one, the D, this is where you get a complicated lesion. And so this is where it gets really dangerous because then you can get, you know, stuff that breaks off and goes to other places and causes problems. They talk about some things that you should be watching when someone has coronary artery disease. So C-reactive protein is a protein that's produced by the liver, and it will tell you if you have a non-specific, if you have inflammation somewhere. So like you can kind of figure out that maybe something's going on from that. Usually it's increased when people have CAD, and chronic exposure to C-reactive protein is linked with unstable plaques and oxidation of LDL cholesterol. And LDL cholesterol is your low density cholesterol. So that's the bad cholesterol. So occasionally you will hear about someone that develops what we call collateral circulation. So as like blood flow is trying to get through an area, if it has a hard time getting through there, sometimes it will go a different way. So normally some arterial anastomosis or connections called collateral circulation exist within the coronary circulation. So two factors contribute to the growth and extent of this. So inherited predisposition to develop new blood vessels and presence of chronic ischemia. So when plaque blocks the normal blood flow, it results in ischemia, and you can get increased collateral circulation because of that. When occlusion of the coronary arteries slows over a long period, there is a greater chance of collateral circulation developing, and the heart muscle may still receive an adequate amount of blood and oxygen. However, with rapid onset CAD or coronary spasm, you don't have that time for it to develop. So you get reduced blood flow and you get severe ischemia or infarction. So this is kind of a picture showing you, maybe someone who has a little bit of collateral circulation. So like here's someone normally with their open functioning artery here. So as they start to get some problems, with this fatty deposits and stuff in their arteries, they actually develop ways where it like goes past that, so because this is so narrow and it can't really get through there well, now this connects with this and now it can go around there and get through. So it's kind of interesting. Okay, so this talks about this person, MP. He is a 58-year-old white male who visits the local health clinic for a physical exam. He tells the healthcare provider that he occasionally gets indigestion when he mows the lawn. It goes away in 5 to 10 minutes after he stops and rests. So typically, if this is the case, then we call this angina. So he gets chest pain when he does stuff, but then when he stops and rests for a little bit, it'll go away. That's typical angina. When obtaining a health history, what risk factors for coronary artery disease would you ask him about? What do you think you would ask him about? Anyone have any thoughts?
Maybe like about his diet and exercise.
Yeah, for sure. Because typically when people have heart problems, it's usually either going to be because it runs in their family. So that would be something we'd also ask about. Hey, do you have people in your family who have had a heart attack or have CAD? And then, yeah, some of those lifestyle things, because usually a lot of this is because of stuff that we do, that we're not active enough, or we are overweight, or we eat really crappy or something, So usually it's that kind of stuff.
Then would you ask about like a smoking history too? Like if you were
for sure. For sure. Yeah, because smoking is a big deal here as well. Definitely. Okay, so here are some risk factors for CAD. These are non-modifiable things that we can't change. So age, gender, ethnicity, family history, genetic predisposition. Unfortunately, those are things we can't do anything about. So down here at the bottom, it says the incidence of CAD is highest among middle-aged men after age 75, and the incidence of serious heart events in men and women equalizes. So then after that, then both men and women both have a lot of incidence of it. On average, women with CAD are older than men who have CAD and are more likely to have comorbidities. So they'll have diabetes and other things going on along with it. Most women have atypical symptoms of angina rather than symptoms of MI when present with their initial heart event. So whenever they have a problem, they'll present totally differently than a male will. So instead of having like chest pain that radiates down their arm, they may feel like more GI type symptoms or jaw pain or something different, you know? It's just not quite the same. African Americans have an early onset and more severe CAD than their CAD counterparts. Additionally, CAD incidence and mortality rates are greater in African American women than their white counterparts. Family history is a high risk factor for CAD and MI. Often patients with angina or MI can name a parent or sibling who has died of this. The genetic basis of CAD and MI is complex and poorly understood. It's estimated that genetic contribution to CAD and MI is as high as 40 to 60%. So that's kind of sad. Like, if you have this that runs in your family, there's nothing you can do about it. The proportion relates mainly to genes that control known risk factors like lipid metabolism. Do you guys have anyone in your family that has high risk factors for CAD or has had problems with this?
Oh, really?
No. I know my mom has high blood pressure and high cholesterol, and she's a little bit overweight and not very active. So my mom is a big risk for this, I believe. My dad's total opposite, though. He totally is not. Okay, so risk factors again. So these are modifiable things now that we're going to talk about. So your cholesterol level. This is something that you could do something about. So you want to see someone's cholesterol lower than 200. So that's kind of what you're shooting for. Your triglycerides is kind of part of all of that. The triglycerides you want to see less than 150. Your high density lipoproteins is your good cholesterol, so you want to see that at a decent level. And your low density lipoproteins, you want to see that lower. So those are some things to pay attention to. Down here at the bottom, it says other things that are modifiable would be elevated blood pressure, like you can do things to try and help with that. Tobacco use, physical inactivity, obesity, diabetes, metabolic syndrome, and psychologic states and elevated homocysteine levels. Do you guys know what metabolic syndrome is? Have you heard of that?
No.
So metabolic syndrome is something that your physician would look at and they would say, oh, you have all of these risk factors, you have metabolic syndrome. So there's like 4 things. So you would be kind of obese and big around the middle, but like your arms and legs would be smaller. You would have a high blood sugar, so you would be diabetic. You would have a high cholesterol, so that would be another thing. And then also a high blood pressure. So all of those things together make up metabolic syndrome. So someone who has metabolic syndrome is going to be more at risk for CAD and other, things to happen further. So that would be something to pay attention to. So if you find someone who has that, you try to get them to modify some of those risk factors so that they can, stop this in its tracks. All right, I'm not going to read through all this. That's all about cholesterol there. Okay, so with hypertension, so I don't know if this is, I don't think this is updated with the new guidelines for what hypertension is, but anyway, yeah, because see, it still talks about pre-hypertension here. So this is old stuff here. But anyway, anytime anyone has like an elevated blood pressure, we want to get them to try and change their lifestyle and to do things to fix that. So once they come into that category as elevated, that's telling you that they're headed the wrong direction. So you need to get them to do something at that point. We have changed all of these guidelines about blood pressure because we know that if we get it under control quicker, that we have a better chance of not developing some of these other comorbidity things. So that's kind of why we made all those changes with that. Tobacco use, that's another thing, you know, this is really huge with people. So it's the third major risk factor for CAD. The risk of developing CAD is 2 to 6 times higher in those who smoke tobacco or use smokeless tobacco than in those who do not. So huge to not smoke. And also, unfortunately, secondhand smoke, if you're around that, that can be a big problem as well. And then a lot of people, you'll come across patients who'll be like, why do I need to stop smoking now? I've been doing it for 50 some years or whatever. And you'll say, well, listen, you know, even if you stop now, you still do get a little bit of a benefit from it. So it will help you with this, this, and this. So you tell them about those things, because sometimes people think that it's not going to make as much of a difference if they stop after doing it for so many years, but it actually does. Okay, physical inactivity is another big thing. This is the fourth major modifiable risk factor. So this implies a lack of adequate physical exercise on a regular basis. So you need to do something like brisk walking 3 to 4 miles per hour for at least 30 minutes, 5 or more times a week. Physically active people who have increased HDL levels, exercise improves thrombotic activity, it reduces clot formation, it can also encourage development of collateral circulation in the heart, so that's a good thing. And plus, obesity is such an issue now with everyone, so you know that can help with that as well. So other things, you know, diabetes and metabolic syndrome, which we just talked about a few minutes ago. Sure, we want to keep our diabetes really controlled, because if that gets out of control, it kind of contributes to everything else as well. And I told you about metabolic syndrome. This talks about psychological states, so certain behaviors and lifestyles that can contribute to this. If someone has like a type A personality, where they're like a perfectionist and they're like they have like a hardworking, driving personality, this person often suppresses their anger and hostility, and they have a sense of time urgency. They're impatient and they create stress and tension. So they may be more prone to having an MI than someone with a different type of personality. So we need to get this person to learn how to relax. So stress is a big deal, you know. So if you have stress, you know, that's going to cause problems for you. So that's kind of what that's about. And then homocysteine level. So high levels of this have been linked to an increased risk for CAD and other cardiovascular diseases. Homocysteine is produced by the breakdown of essential amino acids, which is found in dietary protein. High homocysteine levels may contribute to atherosclerosis by damaging the inner lining of the blood vessels and, you know, promoting that plaque buildup. So that's an issue as well. And then substance abuse also. So people who use illicit drugs like cocaine and methamphetamines can produce coronary spasms, resulting in an MI or chest pain. So that's another thing that people need to stay away from. Okay, 2 risk factors for coronary artery disease that increase the workload of the heart and increase myocardial oxygen demand are, it's going to be hypertension and cigarette smoking. And then this one, which patient is most at risk for developing coronary artery disease? So when you look through these, you're going to look for things that are, you know, put you more at risk. So if you have hypertension and if you smoke, you're going to be more at risk. So this one, A, is going to be the one. Okay, so we want to promote health with everyone, right? So when we talk about people's health history, we also want to include their family history of things. So we want to modify or slowly, slow the progression of the disease process. Prevention and early treatment of heart disease must involve a multifaceted approach and needs to be ongoing throughout the lifespan. If you identify someone who is at high risk, clinical manifestations of CAD will not be apparent in early stages. So it's extremely important to identify people at risk so that you can get them to do certain things to prevent this. So you do this by doing that really thorough health history, question the patient about their family history of heart disease and parents and siblings, note if they have any kind of cardiovascular symptoms, assess their eating habits, their diet, their exercise, psychosocial history, look at all of that stuff because that's going to help you be able to identify them. So when you manage someone who's high risk, you recommend preventative measures. So risk factors like age, gender, ethnicity, and genetic inheritance are not something you can modify. So you work on the things that they can modify. So for example, a young person with a family history of heart disease can decrease the risk of CAD by maintaining an ideal body weight, getting adequate physical exercise, reducing intake of saturated fats, and avoiding tobacco and illicit drug use. So that's kind of things that you would do. Anyone who's high risk, you want to work on educating them about their risk factors and things that they need to be doing. You need to clarify their personal values and set goals that are realistic. Because if you set something that's way out of reach for them, it's not going to help them. For physical activity. So a physical activity program should be designed to improve physical fitness using this FIT formula. So frequency is how often, intensity is how hard, type is isotonic, and time is how long. Everyone should aim for at least 30 minutes of moderate physical activity on most days of the week. In addition, adding weight training to an exercise program 2 days a week can help treat metabolic syndrome and improve muscle strength. Regular physical activity helps with weight reduction and reduces your systolic blood pressure, and in some men more than women, increases in HDL cholesterol. So the HDL is your good cholesterol. So when we talk about nutrition, the National Heart, Lung, and Blood Institute recommends therapeutic lifestyle changes for all people to reduce the risk of CAD by lowering their cholesterol, that bad cholesterol. So we want to decrease saturated fats and cholesterol and increase complex carbohydrates like whole grains, fruits, vegetables, and fiber. Red meat, egg yolks, and whole milk products are major sources of saturated fat and cholesterol and should be reduced or eliminated from diets. So if your triglycerides are really high, alcohol and simple sugars should be reduced or eliminated. Patients with CAD are encouraged to take supplements with their diets, tofu and other things like that, soybeans, canola, walnut, flaxseed. Those are good things to add to your foods because they can help with your overall nutrition. Yeah, I'm going to skip over these little picture things here. This just shows, what's a saturated versus a polysaturated versus a mono unsaturated fat. Okay, the nurse determines that teaching about implementing dietary changes to decrease the risk of CAD has been effective when the patient says, you're going to choose C. Most of my fat intake should be from olive oil or oils and nuts. Okay, so there are medications that we can take to help with our cholesterol levels. So it's estimated that about 31.9 million people in the United States have cholesterol levels greater than or equal to 240, which is horrible. Guidelines for treatment of high cholesterol focus on the LDL cholesterol. So, you know, if diet and exercise is not an effective thing to lowering this, then you put someone on a statin usually. So the statin is going to inhibit cholesterol synthesis and decrease the LDL and increase your HDL. But you also, when they're on the statin, you have to monitor their liver enzymes because it can mess those up. And it can also cause myopathy. What is myopathy, you guys?
Diseases of the muscle.
Yeah, so like if you're on, say you're on Lipitor or something and you're on it for a little bit, it will make your legs feel horrible. Like your legs feel like you get muscle spasms or something and you just can't stand it. That's what that is. Okay, there's a couple other things they mentioned here. So there's a drug called niacin. Niacin will lower your LDL and triglycerides by inhibiting the synthesis of those. But the problem with niacin is it can cause flushing. So it could cause also GI effects, orthostatic hypotension, and itching. So a lot of times to help with that flushing, if people take niacin along with an aspirin, like maybe you take one and you take the other in a half hour or something, it helps with that flushing so you don't have it so bad. So that's something that some people might do. There is another medication called Lopid. This is going to decrease the triglycerides and increase your HDL, but it can have some GI effects with it. So you have to watch for that. Lopid is something that you take twice a day. So you would take it in the morning and the evening. There's also bile acid sequestrants. So these convert cholesterol to bile acids. So you can have some GI side effects from those. And they do bind with other drugs. So you'd have to watch for that. So these, whenever I used to give these to people, this pharmacy used to send it in a pack. It was like some kind of powder that you would mix with like a drink or whatever, and they would drink it. And then Zetia is another med that can help with cholesterol. So this decreases absorption of dietary and biliary cholesterol. I don't see too many people taking that anymore, so I don't know if it's that popular anymore. Also, this mentions some medications like antiplatelet therapy, so aspirin and Plavix. So unless contraindicated, low-dose aspirin, like 81 milligrams, is recommended for most people who are at risk for CAD. Current recommendations include low-dose aspirin for men over 45 and high-risk women. You know, when your doctor figures out your risk, if you have a calculated 10-year CAD risk of greater than 20%, then they would put you on. For high-risk women who are intolerant of aspirin, Plavix can be substituted. In healthy women 65 or older, aspirin may be considered if blood pressure is controlled, and benefit for MI prevention outweighs the risk of GI bleed or hemorrhagic stroke. So all those drugs, you know, aspirin and Plavix, they can cause a big time bleeding risk. So you have to be careful with that. And then when you're thinking about older adults, they have an increased incidence and mortality associated with CAD. So you want to treat their hypertension and their high cholesterol levels and really encourage smoking cessation. Also, for physical activity, you should tell them to do a longer warm-up, longer rest periods, avoid extremes in temperature, and do 30 minutes most days minimum. Obviously, this is going to change when they're hospitalized or symptomatic. Okay, so back to this guy, MP. So MP's health history and physical exam reveals that he has risk factors for CAD. So he has a family history of it. He smokes 1 pack of cigarettes a day. He has a sedentary lifestyle. He has a high-fat diet. Blood pressure is 152 over 94, and his BMI is 30.2. Based on the presence of these risk factors and MP's complaints of indigestion associated with activity, what type of angina is he experiencing? So we're going to say chronic stable angina. So the reason that it's stable is because when he sits down, you know, like he'll stop his activity, he'll sit down and it'll go away. That's why it's stable. If he did that and it didn't go away, that would make it unstable. Okay, so when we talk about angina, CAD is a chronic and a progressive disease. Patients can be asymptomatic for many years and they may develop chronic stable chest pain. When the demand for oxygen, the myocardial oxygen, exceeds the ability of your coronary arteries to supply the heart with oxygen, then you get myocardial ischemia. Angina, or chest pain, is the clinical manifestation of myocardial ischemia. So it's caused by either an increased demand for oxygen or a decreased supply of oxygen. The most common reason for angina to develop is narrowing of one or more coronary arteries because of that atherosclerosis that we talked about in the beginning. This leads to insufficient blood flow to the heart muscle, and for ischemia to develop, the artery is usually blocked or stenosed 70% or more. So when we talk about chronic stable angina, this is intermittent chest pain that occurs over a long period with same pattern of onset, duration, and intensity. It's usually only lasting for a few minutes, and you can control it with drugs. If you were monitoring this person on a heart monitor, you would see an ST segment depression and or a T-wave inversion. So usually when people have this, they're going to get it because they've done some type of physical exertion or stress, or they've had some type of emotional upset. Excuse me. When asked, many patients say they deny feeling pain but describe a pressure, heaviness, or discomfort in their chest. Sometimes they'll say squeezing, suffocating sensation. Sometimes they'll have shortness of breath or fatigue with it. Usually the pain does not change with position or breathing and is rarely described as sharp or stabbing. The pain of chronic stable angina usually lasts for only a few minutes and commonly subsides, usually after they sit down or they take a nitro or something. Pain at rest is unusual and is often a symptom of unstable angina. So a 12-lead EKG often shows ST segment depression and T-wave inversion. That's what's telling you that they have the ischemia. And the EKG will return to baseline when you relieve the pain, which is kind of interesting, right? Chronic stable angina is controlled with drugs on an outpatient basis. Because chronic stable angina is often predictable, drugs are timed to provide peak effects during the time of day when usually they would get the angina. So usually if this person would get it when they wake up in the morning, then they take a drug as soon as they wake up and they wait 30 minutes to an hour before they do any kind of activity. So although most chest pain or angina will occur substernally, like right in the middle of the chest there, it can radiate to other locations. So sometimes people will feel it in the jaw, the neck, the shoulders, or the arms. Many people with angina complain of indigestion or burning sensation in their epigastric region, so like kind of right under where your sternum would be, right there. The sensation may also be felt between the shoulder blades. Often people who complain of pain between the shoulder blades or indigestion dismiss it as being heart related. Some patients, especially women and older adults, report atypical symptoms. So some of the things they might feel would be just shortness of breath, nausea, or fatigue. This is referred to as an angina equivalent. Then there is also something called silent ischemia. So this is going to refer to ischemia that occurs in the absence of subjective symptoms. So patients with diabetes have an increased prevalence of this. This is most likely due to diabetic neuropathy, affecting the nerves that innervate the cardiovascular system. Silent ischemia is documented by EKG changes. Also, this is another type of angina, which I don't know if I can pronounce this right, Prinzmetal's angina, or variant. This is a rare form of angina that often occurs at rest and not with increased physical demand. So you get like a strong spasm of the smooth muscle in the coronary artery, and it results from increased intracellular calcium. Factors causing this would be, increased levels of certain substances like tobacco smoke, alcohol, or amphetamines. When the spasm occurs, the patient experiences angina and transient ST segment elevation. The pain may occur during rapid eye movement, during sleep, when the myocardial oxygen consumption increases, or when exposed to cold temperatures. The pain can be relieved by moderate exercise with sublingual nitro, or it can disappear spontaneously. Calcium channel blockers and/or nitrates are used to control the pain, as well as stopping any offending substances. They also talk about microvascular angina. This is a chest pain that occurs in the absence of significant CAD or coronary spasms of the major coronary artery. So usually the chest pain is related to myocardial ischemia associated with atherosclerosis or spasm of the small distal branch vessels of the coronary microcirculation. Okay, so back to this guy. So while waiting for diagnostic testing, what drug would you expect the healthcare provider to prescribe for MP to use if he develops the indigestion pain the next time he mows the lawn? So usually it's going to be nitro. Can you guys tell me anything specific that you remember about nitro when you learned about that in farm? What would be something that you would want to educate this guy about?
Did you say nitro?
Yeah.
With the nitroglycerin?
Yeah.
Would that be like to apply sunscreen, like the sun exposure and stuff?
Okay. What else would you want to tell him about sublingual nitro?
Oh, to
Sometimes
brush
it
it?
causes headache.
Yes, it can cause headaches. How would you tell him to take this if he was having an episode of chest pain?
Under the tongue.
So you're going to tell him, so he's going to take one, he's going to sit down and relax, and then in 5 minutes, he's going to see if that works or not, right? When should he be calling 911?
If after the chest pain continues.
After he takes one, or should he take more?
3.
Do you wait for 3 to call 911?
No, I don't think so. Yeah.
Typically, they tell you to take one and then wait 5 minutes. And if you have to take another one, usually that's when you call.
Right.
Because they don't want you to wait for the 3, because then that's time wasted that you could have been doing something to do something about it, Because if you're actually having an MI, then you don't want to be messing around with that. So you were talking about sun exposure. So again, when you get sublingual nitro, usually it's in a little vial that's like, I don't know what color that vial is, but you know what I'm talking about. It's like a dark color vial. So it will break down, you know, according to sunlight. So you don't want to store it somewhere where it's going to be in the sun or anything like that. So you would talk about that with this guy too. Okay, so if you have chronic stable angina, so you want to treat this chronic stable angina to decrease the oxygen demand or increase the oxygen supply. So that's kind of what our goal is. So we would give short-acting nitrates. That would be the first-line therapy for treatment of this. So dilating peripheral blood vessels, this results in a decreased SVR, venous pooling, and decreased venous blood return to the heart. So therefore, the myocardial oxygen demand is decreased because you reduce the workload of the heart. Dilating coronary arteries and collateral vessels, this can increase the blood flow to those ischemic areas. So that's kind of what that would do. Sublingual nitro, or maybe like the nitro spray, will usually relieve pain in about 5 minutes and has a duration of approximately 30 to 40 minutes. The recommended dose is you take 1 tablet, put it under your tongue, or you do 1 spray. And if the symptoms are unchanged or worse after 5 minutes, then they should contact the ER or the EMS system before taking another one. If symptoms are significantly improved by 1 dose of nitro, then they can do more. So then they can do it up to 3 times. And then they would contact the EMS if their symptoms have not resolved completely. Instruct the patient in the proper use of nitro. It should be easily accessible, so they should have it somewhere where they can get to it all the time. They should store it away from light and heat to protect it from degrading. And then the tablets are packaged in a dark, airtight container to maintain potency. So once it's open, the tablets tend to lose potency and should be replaced every 6 months. So like if you have it after 6 months and you still have a bunch of them in there, you should just throw it out and get a new thing of them. After they take a nitro, you always want them to sit down and relax too and try to let this work. So it will dissolve pretty quickly. The spray should be directed on or under the tongue, not inhaled. It might cause like a tingling sensation when administered. Warn the patient that a headache, dizziness, or flushing can occur. Caution the patient to change position slowly because they can get that orthostatic hypotension. And then sometimes they'll say patients can take this prophylactically before doing some type of activity that might cause them angina. So in these cases, the patient can take a tablet 5 to 10 minutes before beginning an activity. Tell the patient to report to the healthcare provider any changes like unusual patterns of pain or especially increasing frequency of nighttime angina or angina at rest. All right, so long-acting nitrates. So this would be like a pill or something that they would give this person to take on a normal basis to help prevent some of these angina episodes. So these are used to reduce the frequency of angina attacks. The main side effect of a nitrate is headache from all the dilation of the blood vessels. Advise patients to take acetaminophen to relieve the headache. Over time, the headaches may decrease, but the anti-anginal effects would still, be there and be working. Orthostatic hypotension is a complication of nitrates as well. So you're going to watch for that. So one of these specifically would be Iserdil. This is a one that you see a lot of people get, or Imdur, isosorbide mononitrate. Those are nitrates, so they definitely will help with someone that has angina. Oops, sorry. Also, there are some people who take nitro like through that patch, or I don't know. Did you guys ever get to see like the nitro what the heck's that called? It's so you have like this paper and you squirt out a little bit of nitro on this paper and it measures it. So like you might have 1 inch of nitro paste that you give, and you put this paper on their skin and tape it there. And usually it's something you change every 6 hours. So some people take nitro that way as well. So anytime you would ever get something like that on your skin, it can immediately cause you to have a headache. So you have to be really careful to wash that off and to not get it on you. Okay, what diagnostic testing would you expect the healthcare provider to order for MP? So what do you think they would order if this guy came in with angina? What do you think, what type of testing would they do? No one has a guess?
EKG? Or is it EKG or?
Well, so typically when someone comes in for chest pain, they do a bunch of things, right? So they're gonna draw cardiac enzymes. So they'll probably do that with this guy. They'll probably do an EKG, like you said, to see if he has any changes there. Then they may even order him to do a stress test, right? Okay, so patients with chronic stable angina who have an ejection fraction of 40 or less, and when I say ejection fraction, that means how well the heart is working, right? How well it's pumping blood through there. So if they have diabetes, hypertension, or chronic kidney disease, they should take an ACE inhibitor indefinitely, unless contraindicated. Patients with chronic stable angina with a normal ejection fraction, diabetes, and one other CAD risk factor should take an ACE inhibitor to decrease the risk of MI, stroke, and death. These drugs result in vasodilation and reduce blood volume. So typically you're going to see these people on quite a few cardiac drugs. Beta blockers are ordered to relieve angina symptoms in patients with chronic stable angina. So a lot of times you'll see people on metoprolol for that. Sometimes Coreg, Toprol-XL. So this talks about that a little bit more. We also want to put them on lipid lowering drugs. So if their cholesterol is an issue, we would do that. And then there is a drug called Ranexa that you see a lot of people taking anymore. So Ranexa is a sodium current inhibitor. So it treats chronic angina in patients who have not had an adequate response to other anti-anginals. Not the first-line drug for chronic stable angina. So usually when you see someone on this, they've tried other things first. Common side effects of this would be dizziness, nausea, constipation, and headache. So usually this is kind of some of the stuff they would do. So they might do a chest x-ray, because when someone has chest pain, it could be because of other things. So maybe they have pneumonia or something, and that's why they have the chest pain, you know? So they're going to do a chest x-ray to rule some of those things out. We already talked about doing a 12-lead EKG because they want to see if this person has any changes. The lab studies would usually be, you know, the cardiac enzymes. That's probably something they'll do. And they'll probably look at other labs as well just to see where you're at. The echocardiogram. This is a test that they would do where it's basically just an ultrasound of your heart. So when they do this ultrasound, they can see the structures of the heart. They can see how the blood flows through there. You can see quite a bit just from doing an echo. Sometimes they'll see that there's stuff growing on people's valves, and then they'll be like, oh, we need to do more testing, you know? So there's all kinds of stuff you can do with an echo. The echo is how they estimate the ejection fraction. So they can get that from doing an echo. The exercise stress test. So this would be where you send them to, you know, the cardiac testing lab, and they are going to have them walk on a treadmill. And as they walk on the treadmill, they're going to increase the incline and increase how fast they go and stuff to see what happens with their heart during this. So anyway, when CAD is suspected in a patient with chronic stable angina, usually they do a lot of different studies to figure out what's going on. Okay, so Miss MP's chest x-ray and EKG results are all within normal limits as cholesterol and triglyceride levels are elevated. He develops chest pain and ST segment depression during an exercise stress test. So what additional testing would you expect MP to undergo at this point? So because he did an exercise stress test already and he had chest pain still, you know, I don't know why they have all this written down here, but generally the next step would be to go to a cardiac cath. So they would probably schedule him for that to see what's going on. So for patients with increasing angina, a cardiac catheterization is ordered. This is going to use radiation and IV contrast dye to provide images of the coronary circulation and identify the location and severity of the blockage. If a patient is allergic to IV contrast dye, they have to be pre-medicated. So they still would send them for this, even if they're allergic to IV contrast dye, but they would pre-medicate them with corticosteroids so that they wouldn't have their reaction to it. Patients with chronic kidney disease need hydration pre and post procedure because, again, the dye can affect their kidneys. So you would, you know, maybe you schedule it for the next day, so you start them on IV fluids beforehand, and then you also give them a bunch afterwards to try and clean out that dye from their system. The baseline serum creatinine level is obtained because the IV contrast dye can worsen the renal function. Okay, if a coronary blockage is amenable to treatment, coronary revascularization with an elective percutaneous coronary intervention may be recommended. So in other words, if they're in there for the cardiac cath and they see that there's something there that they could fix with a stent or a balloon angioplasty or something, they're going to do that while they're in there. And that's what the PCI means, the percutaneous coronary intervention. That's what they would do. That's the intervention, to open up that blocked area. During a PCI, a catheter with a deflated balloon tip is inserted into the appropriate coronary artery. The deflated balloon is positioned in the blockage and inflated. This compresses the plaque against the artery wall, resulting in vessel dilation and larger vessel diameter. So this procedure is called balloon angioplasty. So basically they just inflate this balloon and it shoves all that plaque up against the sides of the vessel. So they don't get rid of the plaque, it's still there. It just shoves it up there so that they can have a bigger opening. When they do a stent, they'll do it kind of the same way. They'll be inside that vessel that's messed up and they'll deploy the stent there. And it's kind of like a little mesh thing that opens up to like hold open that vessel. This is kind of what that looks like. So it's an expandable mesh-like structure that keeps the vessel open after a balloon angioplasty. So after they did the balloon to open things up and you know, make all of that plaque get out of the way, they put this stent there to keep open that area so that they don't have problems with blood flow. So there are two types of stents. There's a bare metal stent and a drug-eluting stent. The drug-eluting stents are coated with the drug to reduce the risk of overgrowth of the intimal lining within the stent. This is a primary cause of in-stent restenosis. So the drug-eluting stents would probably be the better one of the two to do. So the most serious complications from stent placement are abrupt closure from a coronary artery dissection and vascular injury at the coronary artery access site, so femoral or radial. Acute MI, stent embolization, coronary spasm, dye allergy, or renal compromise. Sometimes people can have a dysrhythmia during the procedure as well. So other stuff. For patients with refractory stable angina, enhanced external counterpulsation may be used. This consists of placing inflatable blood pressure cuffs around the legs. The cuffs sequentially inflate during diastole and deflate during systole from the calves to the thighs. This action is thought to increase venous return and augment diastolic blood pressure in order to increase coronary perfusion. And then they also talk about spinal cord stimulation. Sometimes that can help as well. All right, so if you're looking at these pictures here, in A, this shows you where they really have a really messed up artery. So it's like really tiny and stenosed in a certain area. So then you see in B how much fatter it is now, you know, so now that they have done the procedure and fixed it with a stent, now it's open and you're getting good blood flow through there. Okay, so this guy MP, he undergoes a cardiac cath. He has a 90% occlusion of his right coronary artery. He has a balloon angioplasty and they put a stent in. So discharge teaching related to CAD and necessary lifestyle changes is provided. He's scheduled for a follow-up with his healthcare provider. 6 months later, he arrives in the emergency department complaining of severe, immobilizing chest pain radiating down his left arm. He admits to not following his healthcare provider's advice related to diet and exercise. He states that he thought the stent opened up his arteries and cured his CAD. The ED physician suspects acute coronary syndrome. Explain this diagnosis. So because he didn't do what he was supposed to, what do you think's going on now?
It's getting worse. Like there's more buildup. Like the buildup is starting to continue inside the stent.
Okay. So because it's getting worse, what do you think could be, like, what's the worst case scenario? So wouldn't worst case scenario, wouldn't that mean that now this is so messed up, this artery is so messed up that really you can't do a whole lot to fix it anymore. So now you're having like not enough oxygen going to that area of the heart, so now that part of the heart is dying. So he's having an actual MI, right? Does that make sense?
Yeah, it does.
All right, so when ischemia is prolonged and not immediately reversible, acute coronary syndrome develops. So when you have acute coronary syndrome, you have either a non-ST segment elevation, so it's a non-ST elevated MI, or you have an ST elevated MI. So when the patients first present with chest pain, the ST elevations on the 12-lead EKG are most likely indicative of a ST elevated MI. The EKG should always be compared to the previous one when possible. So when you look at this whole slide here, so remember he had coronary artery disease, and last time we saw him, it was stable, right? So when he was doing things, he would have chest pain and then he would stop, he would take his nitro or whatever, he was fine. But then he ended up coming in. We did a heart catheterization with him. We did the stent, but he didn't listen to us. So now it went from being stable to unstable. So now he has acute coronary syndrome. So now he's actually having an MI. So before he was not, but now he is, because this is so blocked that now I'm not getting, good oxygenation to an area of the heart. So it's causing that part to die off. So you either have a non-ST elevated MI or an ST elevated MI. So that's kind of where we're at with this. Okay. So when we talk about what's going on with the heart muscle, you basically are hypoxic within the first 10 seconds of a total artery occlusion. So you're completely occluded there now. So the heart cells are deprived of oxygen and glucose is needed for aerobic metabolism and contractility. So anaerobic metabolism starts to take place and you get lactic acid that accumulates. When you have ischemia going on, the heart cells are viable for approximately 20 minutes. So see, there's not a whole lot of time here. So that's why we always tell people, like with the nitro and stuff, to not mess around after that first nitro. If that doesn't work, get right to the hospital, because time is going to be a factor here. So irreversible heart damage starts after those 20 minutes and there's no collateral circulation. Okay, so again, if you get there in time and you can, within that 20 minutes, then hopefully you can save some of those things that can be happening to the heart. Okay, so this is talking about this atherosclerotic plaque that's inside those vessels. So the previously stable plaque ruptures and it releases substances into the vessel. And this stimulates platelet aggregation and thrombus formation. So this area can be partially occluded by a thrombus, so you have a blood clot there, or totally occluded by a thrombus. What causes a coronary plaque to suddenly become unstable is not well understood, but systemic inflammation is thought to play a role. So patients with suspected ACS require immediate hospitalization, so they should always be hospitalized. Okay, so unstable angina is chest pain that's new in onset. It occurs at rest or occurs with increasing frequency, duration, or less effort than what it was like with their stable angina. The pain typically lasts 10 minutes or more. So prompt treatment is needed for patients suspected of having this. The patient with previously diagnosed chronic stable angina will describe a significant change in the pattern of their angina. It will occur with increasing frequency and is easily provoked by minimal or no exertion. They could get it during sleep or even at rest. And then again, you know how women's symptoms are very different. So they could just get things like fatigue, shortness of breath, indigestion, or anxiety. So a myocardial infarction occurs because you have this abrupt stoppage of blood flow through the coronary artery, because you have a blood clot that stopped there, that's like blocked that up. So this causes irreversible myocardial cell death or necrosis. So you actually get a part of the heart that dies off. Most MIs occur in a setting of pre-existing CAD. When a thrombus develops, the blood flow to the heart muscle beyond the blockage stops, resulting in necrosis. So a STEMI, a ST elevated MI, caused by an occlusive thrombus creates an ST elevation on the EKG, and that shows you that they're having an MI. An ST elevated MI is an emergency situation, and in order to limit the infarct size, the artery must be opened within 90 minutes of presentation. So this can be done either by doing a heart cath where they do the intervention, that PCI, or they could do thrombolytic therapy. So do you guys remember learning about thrombolytics, like alteplase or Retavase or those types of things? Do you remember hearing about that?
Kinda. I think so.
So remember, thrombolytics are the only drug that can actually dissolve a clot. The only thing out there.
Yeah.
So you can use thrombolytics in a bunch of different ways, right? So we know that, like, if we have a central line of some sort and one of our ports is clogged, you could use a thrombolytic through there and it can unclog the port. We also know that if you had a vascular issue with your legs or something, like say you were not getting a pulse in that person's foot anymore, and you were worried they were gonna, lose all blood flow to that extremity, you could do a thrombolytic through there to try and open things up. So there's multiple different things you could do this for. Also for strokes, the same type of thing, right? So when someone has a stroke and you know that you've met that time limit that you're allowed to do this for and they meet all the criteria, you can give them TPA. TPA is a thrombolytic. So same thing here now. We're talking about the heart. You have this blockage. You could give a thrombolytic here to try and get rid of that clot to open everything up. So a non-ST elevated MI caused by a non-occlusive thrombus does not cause ST elevation. So if that's what's going on, they do not go to the cath lab emergently because usually they undergo a procedure within 12 to 72 hours if they don't have a contraindication. Usually they don't get thrombolytic therapy, the non-ST elevated people. So an acute MI is going to be something that evolves over time. The earliest tissue to become ischemic is the subendocardium, the innermost layer of tissue in the heart muscle. If ischemia persists, it takes approximately 4 to 6 hours for the entire thickness of the heart muscle to become necrosed. If the thrombus is not completely blocking the artery, the time to complete necrosis may be as long as 12 hours. Okay, so an acute myocardial infarction in the posterior wall of the left ventricle, that's what we're seeing here. This is demonstrated by the absence of staining in the areas of necrosis, where this white arrow is right here, this stuff. Note the scarring from a previous anterior wall myocardial infarction. So this is scarring right here, so from a previous MI. The majority of MIs affect the left ventricle and are usually described based on the location of damage. So either anterior, inferior, lateral, septal, or posterior wall infarction. The location of the MI and the EKG changes correlate with the involved coronary artery. For example, in most people, the right coronary artery provides blood to the inferior and posterior walls. Blockages of the right coronary artery result in an inferior wall or posterior wall MI. Anterior wall infarctions result from blockages in the left anterior descending artery. So not everyone develops collateral circulation, but if present, the degree of collateral circulation influences the severity of the myocardial infarction. Okay, so with the pain, severe chest pain is not relieved by rest, position change, or nitrate administration. That's usually when you know it's an MI. Persistent, unlike any other pain, it's usually described as heavy, pressure, tight, burning, constricted, or crushing feeling. Common locations are substernal or epigastric. When epigastric pain is present, the pain may relate to indigestion and they might take antacids without relief. The pain can radiate to the neck, the lower jaw, the arms, and the back. It may occur while the patient is active or when they're sleeping. It occurs in the early morning hours a lot, and it usually lasts for 20 minutes or longer and is more severe than usual anteanginal pain. Not everyone who has an MI has classic symptoms. Some patients may not experience pain, but may have discomfort, weakness, nausea, indigestion, or shortness of breath. Although women and men have more similarities than differences in their acute MI symptoms, some women may experience atypical discomfort, shortness of breath, or fatigue. Patients with diabetes may experience silent MIs because of cardiac neuropathy or may manifest atypical symptoms like shortness of breath. An older patient may experience a change in mental status, shortness of breath, pulmonary edema, dizziness, or a dysrhythmia. Okay, so during the initial phase of the MI, you get a release of catecholamines that are normally found in these cells. This results in the release of glycogen, diaphoresis, increased heart rate and blood pressure, and vasoconstriction of the peripheral blood vessels. On physical exam, the patient's skin might look ashen, clammy, and might be cool to the touch. In response to the release of the catecholamines, the blood pressure and heart rate may initially increase, but then the blood pressure may later drop because of decreased cardiac output. If severe enough, this may result in decreased renal perfusion and urine output. Crackles, if present, may persist for several hours to several days. Jugular vein distension, hepatic engorgement, and peripheral edema can indicate right ventricular dysfunction. Examination can reveal abnormal heart sounds and may seem distant. Other abnormal sounds suggesting LV dysfunction are S3 and S4 sounds. In addition, you could hear a murmur. So those are some of the things you might see with like a physical exam. A lot of times people experience nausea, vomiting. These symptoms can result from a reflex stimulation of the vomiting center by severe pain. They can also result from the vasovagal reflexes initiated from the area of the infarcted heart muscle. The temperature may increase to 100.4 within the first 24 to 48 hours. The temperature elevation may last for as long as 4 to 5 days. This increase in temperature is due to the systemic inflammatory process caused by the death of the heart cells. Usually within 24 hours, leukocytes infiltrate the area of cell death. You get proteolytic enzymes of neutrophils and macrophages to begin to remove that necrotic tissue by the 4th day. Necrotic zone is identifiable by EKG changes, and then you get a collagen matrix that's laid down. 10 to 14 days after having an MI, the scar tissue is still weak. Heart muscle is vulnerable to stress, and you got to monitor the patient carefully as activity level increases. So a lot of times after someone has an MI, they're very afraid to go do any type of activity. So a good thing to get them to do is to do cardiac rehab, because they go to cardiac rehab and they exercise there, but they're monitored, like on a heart monitor. And so that way, if something happens, they're right there and someone could help them, quickly. Okay, by 6 weeks after an MI, scar tissue has been replaced with necrotic tissue, and the area is said to be healed. So it takes a good 6 weeks. But the area is still less compliant, so it still doesn't work as well as it did. You get ventricular remodeling. The normal myocardium will hypertrophy and dilate in an attempt to compensate for the infarcted muscle. A lot of times people will get dysrhythmias associated with having an MI. This is one of the most common complications. So 80 to 90% of people get a dysrhythmia. So this is caused by ischemia, electrolyte imbalances, or sympathetic nervous system stimulation. So VFib and VTAC are the most common causes of death in pre-hospitalization period. So if someone develops a dysrhythmia with their MI, you know, if someone doesn't get them defibrillated right away, they'll die. Heart failure is also something that's a complication of an MI. So this occurs when the pumping power of the heart has diminished. You get left-sided heart failure or right-sided heart failure. So the left-sided heart failure occurs initially with subtle signs like shortness of breath, restlessness, agitation, or slight tachycardia. Other signs of left-sided heart failure might be, you might hear that S3 or S4 heart sound. They could have crackles in their lungs, orthopnea. If they get right-sided heart failure, this is going to include that jugular vein distension. Their liver might be congested, so it's going to appear bigger, and the lower extremity edema would go along with that right-sided heart failure. Another complication of myocardial infarction would be cardiogenic shock. So when someone has an MI, they can go into shock pretty easily. So this occurs when the oxygen and nutrients supplied to the tissues are inadequate because of the severe left ventricular failure. So this occurs less often with the early and rapid treatment of STEMI, like if someone gets thrombolytic therapy or PCI. When cardiogenic shock does occur, it's associated with a high death rate. All right, other complications, they talk about papillary muscle dysfunction rupture, left ventricular aneurysm. I'm not going to read through all of this because there's quite a few things here. Ventricular septal wall rupture. You can also get something called pericarditis. So pericarditis is inflammation of the visceral or parietal pericardium. So it can occur 2 to 3 days after having an MI. Usually you get chest pain with it that increases with inspiration, and you get coughing. Sitting in a forward position helps relieve the pain. Usually you'll hear that pericardial friction rub when you listen to their heart. So just like when we talked about pleurisy, with this, your heart has like a little area that surrounds it as well. You know how we talked about that pleural space around the lung? Same thing here. There's a little space around the heart as well. And so if you get inflamed right there, that's what pericarditis is. That pericardial sac around the heart gets inflamed, and then as the heart pumps, it's going to rub against that pericardium, and you're going to hear that friction rub. They talk about Dressler syndrome. So this would be when you have pericarditis and you get a fever that develops 1 to 8 weeks after an MI. So they tell you how to treat that. Let me keep going here. I'm just trying to get, this is super long, so I just want to get through this a little bit. Make sure that when you're reading through this, you really look at the stuff about the cardiac enzymes. This is a little bit about it here. That's important. Okay, so we get back to this guy here. So it says identify priority interventions for MP on his arrival to the ED. So last time we talked about him, we said that he was having an MI. So he came back in because he didn't do what he was supposed to do before. So what would be some things that we would do for someone if we knew they for sure were having an MI? What would be some interventions?
Maybe like pain medication.
Yes. What in particular would we reach for for pain medicine for this person?
Morphine,
Morphine.
IV.
Yeah, for sure. Because that's going to work kind of quickly. So you definitely want to give it IV. You don't want to do it any other way. So there is an acronym called MONA, M-O-N-A. So when you think MI, I want you to remember MONA. So some of the interventions that you would do would give, the M stands for morphine, so you're going to give pain medicine. The O stands for oxygen, so you're going to give them supplemental oxygen. The N stands for nitro, so you're going to give them some nitro. And the A stands for aspirin, so you're going to give them some aspirin. So those would be like some of the four main things that you would do for this person. So like they're saying, yeah, we're going to do a 12 lead, of course, you know. We want to keep them in an upright position. You're going to give them oxygen. Make sure they have IV access, of course, right? Nitroglycerin and aspirin. So the aspirin you would give chewable, so it would get in their system right away. The nitro would be sublingual. You're going to give them a statin, and you're also going to give them some morphine. Because we know what's going on here. We know they have a blockage, and we know, you know, these are some of the ways to treat it. So those would be things that we would do. So his EKG demonstrates a significant ST elevation. So yes, it shows he's having an MI. So what evidence-based intervention would you expect to prepare MP to undergo within 90 minutes of arrival to the ED? It's going to be probably a heart cath, right? So an emergent heart cath. So when, you know, if the time limit works for you and you could get him there in time to do the heart cath, that's what you're going to do. But sometimes they take people for a heart cath, and then once they're in there, they're like, ooh, there's such bad disease, I cannot easily stent this stuff. So then what would they do if they couldn't do that? So typically, if you can't fix it with stents, you know, doing a heart cath, then you will probably say that they need to have open heart surgery. So the open heart surgery would just be bypassing those messed up vessels to, you know, restore blood flow to that area of the heart. That's all it is. Okay, so this is just talking about some of the other things you would do for this guy. So if he has a dysrhythmia, you're going to treat that. You're going to do frequent vital signs. He's not going to be allowed to just get up and walk around. He's going to be on bed rest. So you're going to give antiplatelet therapy and heparin. Again, you would send him for a cath probably first, but then if they couldn't, you know, if they got in there and they couldn't stent things like they wanted to, then he would have to go for an open heart. So with the emergent PCI, it's the treatment of choice for a STEMI, you know. So if someone is having that type of MI, that's what you're going to try and do. So the goal is 90 minutes from the door to the cath lab. So once they get into the hospital to when they get into the cath lab. So they would either do a balloon angioplasty and stents, or they would have to take them for open heart, one of the two. So with the thrombolytic therapy, remember how we said that was an option. So sometimes if people aren't a good surgical risk or something, they might try that. So again, you have to meet certain criteria to be able to do this. So there's a whole checklist of things that you have to ask them about. So this is only for patients with a STEMI, so you would not do it for someone with a non-ST elevated MI. And then you have to give it within 30 minutes of arrival to the ER. So you'd have to do it fairly quickly. When you do this procedure, you want to make sure that you establish a really decent IV line, because you have to draw blood frequently while they're getting this thrombolytic therapy. And the thing is, the thrombolytic therapy causes you to be at risk for bleeding. So if I'm constantly sticking someone for blood draws and they're at risk for bleeding, I'm going to have a really hard time controlling that, right? So typically they will put some type of central line in or something while they're getting this, so that when they do have to draw blood, they can just draw it off of the central line, so they don't have to worry about sticking them all the time. Other things here, again, it says monitor closely for signs of bleeding, and sometimes signs of bleeding are not evident. Like, you know, you can look and you don't see it anywhere, but you think maybe something's wrong, right? So one of the things, like with this, when I've seen people get this before, like if they get confused all of a sudden out of the blue, that's telling you that maybe they're having a brain bleed. So you have to be real cognizant of what's going on with them. So watch them really closely. Other things, you probably are going to give them IV heparin in addition to this thrombolytic therapy. Okay, so remember we said if they did go for a cardiac cath and they weren't able to fix stuff, so usually, like this is talking about that. So presence of a left main coronary artery or 3-vessel disease, that's not something they're going to stent. So they're not a candidate for this. So they would have to, you know, have open heart. Or sometimes they try to do a stent and they just can't get it in or something. Or if they have like a history of diabetes, left ventricular dysfunction, or chronic kidney disease, usually they're a better candidate for open heart than they would be for this. When you talk about open heart surgery, it requires incision here on your sternum, and then usually they'll graft like an artery or vein from somewhere else in the body to there, so that they can bypass the area that is having issues. So a lot of times they'll use one out of the leg. So they say the internal mammary artery is most commonly used for this. So during coronary bypass surgery, blood is diverted from the patient's heart to a machine where it's oxygenated and returned via a pump to the patient. So this allows the surgeon to operate on a quiet, non-beating, bloodless heart while perfusion to the organs is maintained. And then, you know, again, the internal mammary artery is usually the one that they do. So like in this picture, you see where the blockage is. And so see, they put the anastomosis here. So they pass that area that's blocked off. So that's kind of what they do there. A radial artery graft is another potential graft. It's a thick muscular artery that's prone to spasm. Perioperative calcium channel blockers and long-acting nitrates can control that. Patency rates are not as good for the internal mammary artery, but better than a saphenous vein, so that could be another option. They also have a minimally invasive direct coronary artery bypass surgery that they could do. This is for patients with disease of left anterior descending or right coronary artery. It doesn't involve a sternotomy, so you wouldn't have to have your chest cracked open. So that would be kind of a nice thing. This would be something they would do robotically, so you would have little incisions. So that's an option for certain people, but not everyone is a candidate for that type of surgery. Off-pump coronary artery bypass. So this is where they do a sternotomy, but no coronary bypass machine. So robotic or totally endoscopic, I can't say it. They can do the coronary artery bypass graft with robotically, basically, is what I'm trying to say. So you can do open heart a few different ways. And then afterwards, drug therapy is going to be very similar to what you would do for someone who had, you know, heart cath. So IV nitro, morphine, beta blockers, ACE inhibitors, sometimes antidysrhythmic drugs if they had an issue with that as a complication afterwards. Always lipid-lowering drugs and stool softeners, because everyone's always constipated after surgery. Okay, so a patient is admitted to the coronary care unit following a cardiac arrest and successful cardiopulmonary resuscitation. When reviewing the healthcare provider's admission orders, which order should the nurse question? So you can see, remember we said MONA was our thing. So oxygen, you know that's right. Morphine, yes, that's right. Nitro, yes, this is right. So the only thing that is not in that MONA acronym is this TPA. So that's what you would question. Okay, I think we're almost done here. There's a few more things. Nutrition therapy. So normally right after surgery, you're going to be nothing by mouth. You're going to progress their diet, and eventually they're going to be on a cardiac diet, which just means low salt, low fat, low cholesterol. So when we mean low salt, we mean like 2 grams salt per day, and that's hardly anything. So it's very difficult for patients. They hate that. Again, we're going to start to get some health information from the patient about some of their past medical history, the drugs that they're on, all of that type of stuff. We're going to get some subjective data from them, talk about family history, indigestion, heartburn. Do they have that when they had their heart attack? All of these types of things. With objective data, we're going to collect things about, their heart rate, their skin, some of our nursing assessments that we do, if there's a pulse deficit, they have dysrhythmias. Okay, so MP undergoes emergent PCI with additional stent placement, this time to a circumflex artery. He is admitted to the coronary critical care unit, and you're supposed to identify appropriate nursing diagnoses for him. So obviously, one of the big ones would be knowledge deficit, right? Because he already didn't do something that he was supposed to do in the past, so we need to make sure he understands better this time what he did wrong last time. Is there anything else you could think of that you could use for a nursing diagnosis for him? No one has a thought? So here's what they say. So they say decreased cardiac output, because obviously he had damage to his heart, right? So his heart isn't working as good as it used to now. Acute pain, because he was having chest pain, right? And then anxiety, because of course this is something that's very scary when it happens. Activity intolerance, before early on we were talking about how he had angina. So when he was starting to do things, he was having trouble just doing his normal activities because he was having chest pain. And then ineffective health management because he wasn't doing what he was supposed to be doing, before when he came back. So with goals, we want to make sure we control his pain, preserve what little good function he does have of his heart muscle. We want immediate and appropriate treatment, effective coping with illness and anxiety, participation in a rehab plan, and reduction of risk factors. That's a really big important thing for him. And this is just like one of the earlier slides. So make sure he's sitting up, give him supplemental oxygen, test his vital signs, 12 lead EKG, nitro, maybe an opioid analgesic if you need it, and then assess heart and breath sounds. You would also give him some reassurance that everything's going to be okay. You're going to do some teaching with him about the drugs that he's on, risk factors, precipitating factors for angina, those types of things. Here's that, a little bit about that MONA acronym. So again, for management from us, we're going to do these things on purpose because what does nitro do to you when you're having a problem with your blood flow anywhere? What does it do to your vessels? Didn't we say that it dilates the vessels? So if we're having a problem either with coronary spasms where your vessels are clamping down or that you can't get blood flow through good enough, this will help open things up a little bit more. And then the oxygen is going to help with, maybe some of his symptoms that he's having. Same with the morphine. And the aspirin is only to help with preventing further episodes of this. It's they've done studies about this. All right, and then they talk about things like anxiety reduction, emotional and behavioral things that you can do. Consider open visitation. Make sure he has social support. All right, and then we kind of have already done this, so I'm not going to keep harping on that. Okay, I feel like this keeps saying the same things over and over again. Okay, so for this one here, this is talking about if someone had open heart surgery. It's called a coronary artery bypass graft, a CABG. So typically after they have that done, they're going to be in the ICU for about 24 to 36 hours. And that's going to vary depending patient to patient on how they do. So if they have a lot of complications, they might stay in there for longer. They're going to have a pulmonary artery catheter placed. They're going to have an art line. They're going to be continuously monitored by their EKG. They're going to have multiple chest tubes. They're going to have a pleural and a mediastinal one. They're going to be intubated and have an ET tube put in. They are going to have pacemaker wires that are placed during surgery that they'll have available to them afterwards. They're usually going to have a catheter and probably an NG tube. So lots of things that they're hooked to. All right, and then this is talking about complications. So of course, bleeding would be a big complication after surgery or even after your stent placement. So bleeding would be a big deal, so you would watch for that. Fluid and electrolyte imbalances would be another thing. Hypothermia also, and then infection. So for the open heart patient, some of the big complications, AFib is like a huge complication after this. This is super common, and I used to see this all the time with people. They would go into AFib after open heart. Some of their fluid and electrolyte issues would be a problem too, and then bleeding. So if someone had a bleeding issue, like they say they got out of surgery and they came right to ICU and they started bleeding up a storm, and no matter what you did, you couldn't get it controlled, then they would probably take them back to surgery emergently to try and fix that. So we're going to do specific surgical site care. They're going to have multiple incisions. They'll have a leg incision and a sternal incision, and then also wherever their chest tubes are, you're going to have to take care of all of that. We're definitely going to manage their pain, and then DVT prevention, of course we're going to do that because they're going to be on bed rest for a while. So they're probably going to get sub-Q heparin. You're going to have SCD pumps on them, you name it. You're going to get them up early. So probably even in the ICU, even if they're intubated still, you might still get them up to a chair. What pulmonary hygiene means is that we're going to really keep close track of their lungs. So we're trying to prevent pneumonia and things like that from happening. So we're going to really push some of these lung things that we do, like coughing and deep breathing and suctioning and giving breathing treatments and whatnot to help prevent this from happening. And then we're going to watch their cognitive function really closely. Cardiac rehab, again, is a really good thing for people after they've had some kind of cardiac event. They teach all kinds of things there. So they talk about like how to eat right, how to stay active, um, different things that you wouldn't think that they would teach. They do a lot of stuff, so it's really nice. All right, so when discussing activity restrictions and expectations after discharge with this guy, he assumes his sex life now is over and he does not want to die having sex with his wife. How will you respond? So, believe it or not, this is kind of a common thing that a lot of people worry about after open heart. So, once he is cleared by his physician, he's okay, and it's okay to resume having sex. And so you have to have a discussion with him about this and, just about how things are different. Okay, real quick towards the end here, it mentions a little bit about sudden cardiac death. So this is unexpected death from some cardiac cause that you probably didn't even know someone had. So I know my kids who do sports at school, every time we have to do that big sports meeting before the season starts, they always show us the sudden cardiac death video that we have to watch. So unfortunately, there's people out there that don't realize they have a heart issue and they could be playing a sport or something and just fall down dead, right then and there. So we've seen it a lot in different places. So that's kind of what this is about. So it's just a abrupt disruption in cardiac function, resulting in a loss of cardiac output and cerebral blood flow. So typically it's either going to be because they have a structural heart disease, a ventricular dysrhythmia, or some kind of conduction disturbance. Usually you have no warning signs whatsoever. Prodromal symptoms, if associated with an MI, so if they actually have an MI with this, they might get some symptoms, so chest pain, palpitations, shortness of breath. Death usually happens within 1 hour of onset of these acute symptoms, so super important to pay attention to any of that. So anytime, like you say you caught someone who did something like this, like they passed out and they started having all of these weird symptoms, you would try to work them up for everything under the sun once you brought them into the hospital to see what was going on. And this person may end up with a pacemaker or something, who knows? So it's really important to pay attention to any of that stuff. Like on this slide here, it talks about a 24-hour Holter monitor. This is a heart monitor that you would wear at home, and every time you would notice any kind of weird symptoms, you would push this button to like make a note of it on their stuff. And then after 24 hours, the doctor would be able to look at all the data that he got from this to see if you had any kind of dysrhythmias or anything. Some of the other stuff they mentioned on here, the electrophysiologic study, this is something specific to heart rhythm problems. So they take you to the cardiac lab and they try to, if they know what specifically is happening with you, they try to actually make it happen in the lab, and then they can see where it's at, and then they it's hard to explain, but they kind of like burn that area to try and fix it. So almost like cauterization or something right there. And that fixes the conduction issue that you're having. And then down at the bottom, it mentions life vest. Life vest is something that sometimes people will have to wear when they have cardiac issues that maybe they need, like a pacemaker or something. They haven't been able to get it yet. So they put someone in this life vest to be able to kind of shock them out of this crazy rhythm if they go into it again. So it's kind of crazy, but I have seen people have to wear those. So yeah, so anytime you have to teach people about symptoms of cardiac arrest and what they can do to help save their lives, It's very life changing when you have any kind of issue like that. So when caring for these patients, be alert to their psychological adaptation to this sudden brush with death. Many of these patients develop a time bomb mentality and they fear that they're going to have this happen again, and they get real anxious and angry and depressed. Sometimes their caregivers feel the same way. So patients and caregivers may need to deal with additional issues such as driving restrictions, role reversal, and change in occupation even. So the most significant factor in long-term survival of a patient with sudden cardiac death is going to be B, rapid institution of emergency services and procedures. So typically, if you ever see someone go down, like you're out in the community somewhere, if they go down, obviously call 911 and you would start compressions, but have someone get a defibrillator as soon as possible if there's one anywhere close by, because typically if it's a rhythm issue, that's going to help you more so than anything. The nurse is caring for a patient who survived a sudden cardiac death. What should the nurse include in the discharge instructions? You're going to do C. Your family members should learn how to perform CPR and practice these skills regularly. So that's that stuff. So that's why I usually don't do these PowerPoints, because they're so stinking long. But yeah, so that's the coronary artery stuff that we were going to do today. So we will break here and stop and come back to lab at 12:30. In lab, I'm going to talk specifically about certain skills that we need to know how to do, so we'll do that first. And then I may talk a little bit about heart failure after that, so we can get that in. Questions? Okay, guys, I will see you at 12:30.